Let's take a look at the analgesia and pain management. This is going to be a big part of your practice. Primary care providers, advanced practitioners do treat a lot of patients with pain, and you'll become very familiar with the different medications and their uses. So let's just take a quick overview of the drugs. Opioid agonists, which are the phenanthrins, which include the morphine sulfate, codeine, hydrocodone, oxycodone, hydromorphone, the phenylpipridines, or this is the demerols or the fentanyls, the meperidines, the diphenylheptanes, which is the methadones, and the propoxyphens. We have the mixed agonist-antagonists, such as toluene, and the partial agonists, such as Ultram or tramadol. Indications: these drugs are for the symptomatic treatment for moderate to severe acute pain, used to induce sedation as a form of anesthesia, such as preoperative medication, for post-surgical pain, severe diarrhea and cramping, dyspnea related to left ventricular failure or pulmonary edema. We see a lot of morphine used for this. And methadone, which is the only one drug used for detoxification of opioid addiction. And codeine is also used as indicated for persistent cough treatment. So let's start with the opioid agonists. Opioid analgesics are thought to inhibit painful stimuli in the substantia gelatinosa of the spinal cord, brainstem, reticular activating system, thalamus, and limbic system. Opioid receptors in each of these areas interact with the neurotransmitters of the autonomic nervous system, producing altercations in reaction to painful stimuli. The opioid action of the drug manifests as analgesia, sedation, euphoria, mental clouding, respiratory depression, meiosis, decreased peristaltic motility, depression of the cough reflex, and orthostatic hypotension. The opioid receptors in the CNS mediate analgesic activity. Opioid agonists occupy the same receptors as endogenous opioid peptides, and both alter the central release of neurotransmitters from afferent nerves sensitive to noxious stimuli. Actions of the opioid analgesics can be defined by the activity of three specific receptor types: the mu, the kappa, and the delta. The mu receptors mediate morphine-like supraspinal analgesia, meiosis, respiratory depression, euphoria, physical dependence, and suppression of opiate withdrawal. The kappa receptors mediate spinal analgesia, respiratory depression, and sedation. The delta receptors mediate agonist activity. Morphine-like agonists have activity at the mu, kappa, and delta receptors. Mixed agonist-antagonist drugs such as fentazoxine have agonist activity at some receptors and antagonist activity at other receptors. The opioid antagonist naloxone does not have agonist activity at any opioid receptors. The mechanism by which opioids produce euphoria is not exactly clear. They alter hypothalamic heat regulation in such a way that the body temperature often falls slightly. They also affect the hypothalamus by causing decreased levels of testosterone, cortisol, ACTH, and beta endorphin. With long-term use, this effect diminishes. CNS effects in the limbic system can induce induce dysphoric mood, especially in long-term use, intense and unusual dreams, and hallucinations. This is why you see patients on these medications having hallucinations at night. Pupillary meiosis results from excitatory effects of the parasympathetic nerves that cause constriction of the pupils. The respiratory depression associated with opioids is caused by direct effect on the brainstem respiratory centers, by which the brainstem becomes less responsive to carbon dioxide. Death from morphine overdose is usually a result of this respiratory arrest. The cough reflex is depressed by a direct effect on the cough center in the medulla. This event is separate from respiratory depression, so they work on separate receptor sites. Opioids produce nausea and vomiting through direct stimulation of the chemoreceptor trigger zone for emesis in the medulla. The vestibular component is part of the effect, in that nausea and vomiting are more common in ambulatory patients than those who are on bed rest with this medication. Opioids produce a peripheral vasodilation, reduce peripheral vascular resistance, and inhibit baroreceptor reflexes, causing orthostatic hypotension and fainting. The effects of opioids on the GI system are many. They decrease gastric motility, thereby prolonging gastric emptying time and increasing the likelihood of esophageal reflux. With opioid use, the absorption of other orally administered drugs is also reduced. Opioids diminish biliary, pancreatic, and intestinal secretions. The sphincter of Oddi constricts and causes increased pressure in the common bile duct, leading to biliary colic. This is why you don't want to give morphine or opioids to patients who are undergoing HIDA scans because of this constriction on the common bile duct. Opioids also delay digestion of food in the small intestines. Propulsive peristaltic waves in the colon are diminished, and the tone is decreased to the point of spasm. This delays the passage of stool and leads to constipation. This is a major concern for postoperative patients who are awaiting the return of bowel function, because they do have pain, which is often treated with these opioids. However, this medication does slow the passage and thus increases the incidence of postoperative slowing of return of the bowel function after postoperative procedure. Opioids inhibit the urinary voiding reflex and may cause urinary retention. This also may prolong labor. Opioids can cause dilatation of cutaneous blood vessels, resulting in flushing. Some opioids, morphine and meperidine, but not methadone or fentanyl, cause a histamine release. This may lead to pruritus, sweating, and urticaria. This is why you often see patients who have had morphine and Dilaudid who are frequently itchy. The opioids affect the immune system in a manner that is poorly understood, but they do seem to cause suppression of natural killer cells. The mixed agonists-antagonists produce potent analgesic effects by stimulating the kappa receptors and blocking the mu receptor. They produce withdrawal symptoms in patients with opioid dependency, but are also less likely to be abused when compared to the pure opioid agonists. In addition to central opioid receptor agonist activity, tramadol exerts norepinephrine and serotonin reuptake inhibition in the CNS. This inhibits pain transmission in the spinal cord. The norepinephrine reuptake inhibitors, such as tapentadol, is a fairly new synthetically derived centrally acting oral analgesic. In addition to central opioid receptor agonist activity, it activates the mu opioid receptor and inhibits norepinephrine synaptic reuptake. Norepinephrine reuptake inhibition appears to have an additive analgesic effect to that of the drugs of opioid activity. So let's take a look at the treatment principles, evidence-based recommendations. Some evidence suggests that long-term management of chronic pain with opioids may significantly improve functional outcomes and the quality of life. Morphine is effective in providing relief of moderate to severe pain, but is associated with the adverse effects of constipation, nausea, and vomiting. There's limited evidence suggesting that there's very little difference between hydromorphone and the other opioids in terms of analgesic efficacy, adverse effects, and patient preference. There's also limited evidence indicating that methadone is effective for relief of cancer pain and is available for administration via multiple routes. Randomized controlled trials have been conducted to support the practice of switching opioids to manage inadequate pain relief and intolerable side effects. These are lacking, and we need more research in this area. For the cardinal points of treatment, to avoid problems with prescribing, opioids, the provider must follow federal and state regulations and commonly accepted guidelines. Chronic pain requires routine administration of drugs. Giving medication before pain is severe means that the patient will use less of the drug. The clinician should instruct that medication be given regularly without waiting until the patient is in severe pain and is begging for medication. Long-acting preparations should be considered for patients with chronic pain. Many of the experts agree that addiction generally is not a concern, especially for patients with chronic pain or terminal illness. Primary care providers should be comfortable about treating patients who have chronic pain. Pain of greater severity may be relieved by combining therapies. More severe pain may require addition of an opioid preparation that is useful at higher doses. Analgesic adjuncts may be useful. Frequent follow-up is needed to assess outcomes and side effects, provide reassurance, and establish goals with the patient. It is unrealistic to expect total pain relief if a patient has chronic pain. Concurrent problems such as depression, anxiety, and insomnia add to the perception of pain in many of these patients and needs to be addressed as well. The variety of patients who present with pain is extensive, and treatment should be individualized to the patient's response. Acute, mild to moderate pain, such as that seen with sprains and strains, is commonly managed in the primary care setting. Acute severe pain usually is managed in an acute care setting to address the underlying causes, such as acute myocardial infarction or fractures. Chronic pain, both benign and malignant, is managed in primary care or by referral to specialty pain management clinics. Hospice referral is important for the management of pain and other symptoms associated with terminal disease and dying. Because of reimbursement mechanisms and changes in practice, pain management is being moved increasingly from the primary care setting to that of the specialists, such as the pain management centers. Patients with chronic pain may have multiple problems, including psychiatric responses to chronic pain and other comorbid conditions. Simply prescribing a pill is not an effective way to manage pain. These patients require a comprehensive pain management program that includes the patient, the family, caregivers, along with the healthcare providers, including specialists. The plan must be consistent from one healthcare professional to the next, and primary care clinicians may have to refer patients to pain management clinics for evaluation and specialized treatment, such as nerve blocks, hospice referral as well, especially for those terminal conditions. In 2011 CDC report revealed that more than 40 people die each day due to an overdose of prescription painkillers such as Vicodin, methadone, Oxycontin. that are routinely prescribed for medical or dental problems. Painkiller overdoses causing death has more than tripled in a decade, and clinicians should clearly assess patients before giving prescriptions and when patients return for follow-up care and more medication. The National Survey of Drug Use and Health found that 1 out of 20 people aged 12 and older claimed they had used prescription painkillers for non-medical reasons in 2010. This is also becoming a great concern with the opioids, especially heroin. There's been an increasing number of deaths related to heroin overdoses. If opioids are to be used, particularly in patients who have never been on opioids, you should start at the lowest possible dose. If converting from one opioid to another, use an equivalent dose. There are many charts that have equivalent doses of different opioid drugs. Adjust the dosage to achieve pain relief with acceptable levels of adverse effects. Titration rate it depends on the half-life of the selected opioid, so you need to be aware of this. And there is no ceiling effect seen with analgesia and pure opioid agonists. The ceiling is limited only by the side effects. Opioids are used in both chronic and acute pain. Codeine sulfate was recently placed on the FDA list of drugs to monitor because of respiratory depression or arrest resulting in death in children taking codeine who are CYP2D6 ultra-rapid metabolizers. The FDA Drug Safety Commission may place restrictions, more restrictions on this population as time goes on. If non-opioid medications are not effective, opioids alone or with Tylenol or acetaminophen can be used for non-malignant and malignant pain. Adjunct drugs are used to alter pain perception, useful in neuropathic pain alone or in combination with NSAIDs or opioids. So what are the steps for changing opioids if a patient is on a medication that is not effective? You need to calculate the 24-hour dose of current opioids, including around-the-clock and rescue doses. Use an equivalent table to convert the dosage of the current drug to an equivalent dosage of the new drug. Adjust the dosage of the new drug to accommodate patient variability and to account for incomplete cross-tolerance. Determine the drug dosage interval according to the duration of action of the new opioid and calculate rescue doses as well. Guidelines for starting doses of new opioids. After the 24-hour dosage of the new opioid has been determined, reduce the dosage by 25 to 50% based on the patient age, pain intensity, renal hepatic dysfunction, and incomplete cross-tolerance. A new dosage may have to be reduced by 75% when one is treating frail elderly patients who have moderate pain, major organ dysfunction such as renal hepatic disease, or a history of adverse reactions to opioids. Rescue doses are rarely ordered by the primary care clinician except in hospice care. However, administer rescue doses to patients to relieve breakthrough pain that occurs despite their regularly scheduled around-the-clock regimen. Give 5 to 15% of their 24-hour oral dose as a rescue dose. Administer oral rescue doses every 1 to 2 hours as needed, and administer parenteral rescue doses every 15 to 60 minutes. When terminating treatment, provide a written letter documenting that the therapy will be discontinued, provide a 30-day supply of medication, and give patients recommendations of for where to go for treatment. This can occur when you're moving to a different practice or for a number of reasons. Again, guidelines, you should follow the guidelines for starting new doses and rescue doses. It's important to have an administration schedule that the patient understands and individualize the management of the patient according to their response. The patient does require a comprehensive program, especially for chronic pain, which is provided by pain management clinics or hospice care. So how do we monitor these patients? The severity of pain experienced by the patient determines which parameters should be monitored. The initial database should be used to formulate treatment goals and monitor progress. The patient who is taking opioids should be seen at least weekly until the pain is controlled, and then and perhaps more frequently, depending on the nature of the condition. Once stable, the patient should be seen on a regular basis. You need to assess for therapeutic effect, use a standard pain assessment tool, assess the patient for the occurrence of common side effects, dependency, and interference with activities of daily living or lifestyle patterns. Most patients on opioids do become constipated, so you need to address this. Monitor for nausea, especially when the patient is starting to take opioids. Monitor for behaviors that may indicate misuse or abuse, such as unsanctioned dose increases, losing prescriptions, and resisting change to medication regimens. For very frail patients, specific signs and symptoms that should be assessed at baseline and as necessary when the patient is taking medications include vital signs, including especially orthostatic blood pressure, respiratory function, rate, breath sounds, and blood pressure, heart sounds. In the abdomen, you need to listen for abdominal sounds, bowel and urinary functions, and for psychiatric issues, you need to look for dysphoria, confusion, disturbing dreams, insomnia, and hallucinations. For patient education, you need to instruct the patient to take medications exactly as prescribed. It may be important for them to write down times when medications were last taken to prevent overdosage. Work to taper doses if taken over a long period of time. Although the product has a potential for addiction, used properly, this should not be a problem. It is most effective when taken before the severe pain is experienced, so tell your patients to take it on a schedule rather than waiting for the pain to become so severe. They should use other methods for relieving pain whenever possible, and they should not take any other medications without informing the healthcare provider. They should not drink alcoholic beverages while taking these medications. The patient should inform the healthcare provider of all prescribed over-the-counter and herbal medications that they're taking. They need to report any new troublesome symptoms, such as constipation, suppression of a cough reflex, dizziness, nausea, drowsiness, sweating, and flushing. After the patient has taken the medication, they should avoid operating heavy machinery, driving, or performing tasks that require alertness. They should urinate frequently and monitor bowel habits daily. They need to report any problems associated with constipation. They should rise slowly from a lying or sitting position to minimize feelings of lightheadedness. Avoid standing in one position for long periods of time. During the initial doses, they should lie down for short periods to avoid developing any nausea. And family members should alert healthcare providers if they notice that the patient has presence of shallow, slow respirations, shortness of breath, pupil constriction, deep sleep, vomiting, abdominal pain, palpitations, or skin rash. These medications must be kept out of reach of children and all others for whom it's not prescribed for, and the patient should dispose of all extra medication when it's no longer needed. They should not keep the medication for another time in case they have more pain. They should not share the medication with any other persons. For patients' variables, geriatric patients, elderly, patients are more susceptible to CNS side effects of opioids and to constipation. Usually they should be placed in a bowel regimen when opioids are started, that you should use a lower dose of opioids in the elderly, and you should use caution when using propoxyphen, tramadol, and methadone in these patients. For the pediatric patient, children do experience pain in the same way that adults do. Sometimes they have greater difficulty communicating their pain, so you as a provider must be alert. A pain scale that uses smiling and frowning faces may facilitate assessment of pain. Use morphine, codeine, and meperidine, but do not use oxycodone, propoxyphen, methadone, and pentazocin. The safety of hydromorphone in children has not been established. For those patients that are pregnant and lactating, most of the drugs are considered Category C, Category D with prolonged use or high doses at term. Oxycodone belongs to Category B. However, maternal addiction and neonatal withdrawal occur after illicit use. Some association of first trimester exposure and congenital defects with codeine has been shown, although significant respiratory depression of the mother may be lacking when morphine is administered before delivery. The neonate may experience respiratory depression because of immature blood-brain barriers. Opioids do cross the placental barrier and are excreted in the breast milk. Some early research suggests that women who use common pain killers such as ibuprofen and naproxen early in pregnancy may have a 2.4 times higher risk of miscarriage. So let's look a little at the specific drugs. Morphine, also called MS-Contin, is a Schedule II drug. Other opioids are compared with morphine in terms of efficacy. Morphine is the primary opioid analgesic used for relief of severe pain. It is classified as a Schedule II controlled substance. Morphine is more effective against dull, continuous pain than for sharp, spasmodic pain. It's contraindicated for those who are hypersensitivity, who have a hypersensitivity to opioids, have acute bronchial asthma or any upper airway obstruction, for premature infants or during the delivery of a premature infant. Epidural or intrathecal morphine should not be given in the presence of infection at the injection site or to a patient on anticoagulation therapy or with any condition or medication therapy that would contraindicate epidural or intrathecal anesthesia. It should be not be used with respiratory insufficiency, CNS depression, increased intracranial pressure, acute alcohol intoxication, convulsive disorders, heart failure secondary to chronic lung disease, and cardiac arrhythmias. Caution should be used with patients. It should be contraindicated in patients taking MAOIs or have received MAOIs within 14 days, as well as pregnant patients, prolonged use or high use at term. For warnings, fetal overdose may result if extended release form is chewed, crushed, or diluted. In case of head injury and increased intracranial pressure, opioids may obscure clinical pictures, so you should use these cautiously. You should use cautiously in asthma and other respiratory conditions. Because they depress the respiratory drive while increasing airway resistance, and these products can cause severe hypotension, especially in patients at risk for orthostatic hypotension. You need to use precautions when giving to patients with renal hepatic dysfunction because these products may have prolonged duration and a cumulative effect, requiring reduced dosage and longer intervals between dosages. Opioids may obscure diagnosis of acute abdominal conditions, so you need to use this with caution. You need to use caution in patients who are elderly, debilitated, hypoxic, or sensitive to CNS depressants, and in those who have hypercapnic cardiovascular disease, myxedema, convulsive disorders, increased ocular pressure, acute alcoholism, delirium tremors, cerebral atherosclerosis, ulcerative colitis, fever, decreased respiratory reserve, hypothyroidism, kyphoscoliosis, Addison's disease, prosthetic hypertrophy, urethral stricture, CNS depression, coma, glaucoma, gallbladder disease, recent GI or genitourinary tract surgery, or toxic psychosis. You need to use with caution in patients with supraventricular tachycardias. Vagolytic action may increase the ventricular response rate and make these worse. Opioids do suppress the cough reflex, which may be a problem in elderly or frail patients with pulmonary problems and may increase the risk of aspiration. Some products do contain sulfites, which produce asthma-like symptoms in sensitive individuals, and these agents may produce drowsiness or dizziness. You need to advise your patients to observe caution when driving or performing other tasks that require alertness. You also need to monitor for drug abuse and dependence. The pharmacokinetics of morphine opioids are readily absorbed from the GI tract. They are more lipophilic. Opioids that are more lipophilic are absorbed through the nasal or buccal mucosa and through the skin. All are readily absorbed after subcutaneous or intramuscular injection. Oral opioids undergo a variable but significant first-pass effect and thus decreasing the bioavailability of oral preparations. Morphine is 17 to 33% bioavailable, and the time effect curve is prolonged by oral route. This lengthens the duration of action as well. Approximately 30 to 35% of the drug is protein bound. Opioid analgesics are metabolized in the liver through glucuronidation and to a lesser extent by the cytochrome P452D6 enzyme system. They are excreted through the kidney in a conjugated form, and genetic variability produces wide differences in how quickly opioids are metabolized. All opioids are excreted in the urine. Some are excreted to a small extent in the feces. For adverse effects, most common adverse effects include constipation, dry mouth, headache, lightheadedness, dizziness, sedation, nausea, vomiting, and sweating. There are many more which you can look these up. For drug interactions, they interact with drugs metabolized by the P452D6. With analgesics, in general, CNS depressants effects may be potentiated by use of other opioid analgesics, alcohol, anti-anxiety agents, barbiturates, anesthetics, non-barbiturates, sedative hypnotics, phenothiazines, skeletal muscle relaxants, and tricyclic antidepressants that are used at the same time. Respiratory depression, hypotension, profound sedation, and coma may also result. The use of opioids with Lasix may aggravate or produce orthostatic hypotension, and concurrent use of opioids with anticholinergics may produce a paralytic ileus. The phenothiazines enhance the sedative effect of opioids. Plasma amylase and lipase levels may be unreliable for 24 hours after administration of opioids. Morphine may potentiate the anticoagulation effect of warfarin. For overdosages of morphine, signs and symptoms include, for the acute overdose, profound respiratory depression of a rate less than 12 breaths per minute, irregular and shallow respirations, deep sleep, stupor, or coma, meiosis, cyanosis, gradually decreasing blood pressure, olguria, clammy skin, and hypothermia. For chronic abuse overdose, signs and symptoms include constricted pupils, skin infection, mood changes, depressed level of consciousness, itching, needle scars, and abscesses. For dosage administration, the dosage and formulation depend on the severity of pain experienced by the patient, the response to pain and medication, the nature of the illness, and the route of administration. This category may be administered via oral, rectal, sublingual, intramuscular, subcutaneous, and intravenous routes. The oral route is used most often in primary care, except in terminally ill patients. In some patients with chronic pain, long-acting delivery systems may be used more often, along with transmucosal systems for breakthrough pain. For those with chronic pain, you may need to refer the patient to hospice for assistance for greater dosages to help with this pain. Morphine sulfate comes in an oral solution as well, 100 mils per 5% strength, and immediate release and extended release formulations. The immediate release formulation, IR morphine, is given for breakthrough pain. IR morphine comes in tablet as well as liquid formulations. Morphine oral concentrate at 20 milligrams per mil can be used sublingually in patients who are unable to swallow. This is often used in hospice. The extended release formulations such as MS Cont are used for routine administration for chronic pain. MS Cont is commonly used in hospice. Given twice a day, it provides around-the-clock pain control. MS Cont can be given rectally when the patient is unable to swallow as well. Morphine sulfate extended release capsules consist of two components, an immediate release component that rapidly achieves plateau morphine concentrations, and an extended release component that maintains plasma concentrations throughout the 24-hour dosing interval. The amount absorbed is similar to that absorbed in other forms of oral morphine. Morphine sulfate extended release capsules, MBDA, have a subsequential core of naltrexone that is released if the capsule is chewed, crushed, or dissolved, rendering it ineffective. This makes it less desirable for abuse. The extended release formulation of morphine must be taken correctly. Tablets must be swallowed whole and must not be chewed, crushed, or dissolved. If they are, the patient may receive a fatal overdose. Guidelines for long-acting medications are published to help patients maintain as much of their normal life as possible. The use of adjuncts may decrease the overall narcotic use. Patients can take one capsule in the morning and go out and function all day long. They do not have to take the medication with them for those extended release forms. How about the other drugs in this class? They're similar. Codeine is a Schedule II/III drug. It has two primary therapeutic effects, analgesics and antitussive. 10% of codeine is metabolized to morphine. Codeine is relatively less potent than morphine and does not have the abuse potential of morphine. It's more likely than other opioids to cause constipation and nausea, and often is combined with non-opioid analgesics, centrally acting muscle relaxants, antihistamines, and decongestants. Non-combination forms of codeine are classified as Schedule II. Controlled substance, oral codeine is as effective as parenteral form. For the hydrocodone, which is Loratab, Vicodin, are Schedule IIIs. Hydrocodone is a semi-synthetic opioid with primary actions that affect the CNS and smooth muscle organs. Its principal actions are analgesic and sedation. It's similar to codeine in that at least 1/2 of its analgesic activity is retained in the oral form. It is used to treat moderate to severe pain of an acute nature or as an antitussive. It's available in combination only with acetaminophen, aspirin, or ibuprofen, and with antihistamines, decongestants, and expectorants for cough suppression. Similar to morphine, hydrocodone produces drug dependence. It should not be used in patients who are hypersensitive to any of the combination tablets ingredients as well. Hydrocodone preparations may be less constipating than codeine, especially in older adults. For the oxycodone, which is a Percocet with acetaminophen, OxyContin, these are Schedule II drugs. They're similar to hydrocodone. It's a semi-synthetic opioid that's similar to codeine in that the oral form, it retains at least 1/2 of its analgesic activity. The immediate release form is used to treat moderate to severe pain. The controlled release form is indicated only for chronic pain that requires continuous analgesia for extended periods. It's not to be used on an as-needed basis. Controlled release tablets are not to be broken, chewed, crushed, because this allows for rapid release and absorption of a potentially lethal dose of oxycodone, particularly with the 80 and 160 milligram tablets. These high-dose tablets are to be used only for those with opioid tolerance because they have become very popular for drug abuse. Oxycodone is available in combination with aspirin or acetaminophen. Similar to morphine, it does produce drug dependence. Oxetat, a long-acting form of oxycodone, contains niacin, which is designed to cause uncomfortable flushing and skin irritation if a person takes more than the recommended amount. It is an abuse-resistant form of oxycodone. Hydromorphone, Dilaudid, is a Schedule II medication. It's a very potent synthetic effects that maximizes effects and minimizes some of the common effects common side effects seen with morphine. Hydromorphone is approximately 5 to 7 times the potency of morphine. 10 milligrams of morphine is equivalent to 2 milligrams of hydromorphone. Hydromorphone produces less sedation, nausea, vomiting, and constipation than its counterpart. The incidence of associated respiratory depression is marked, requiring close observation. You should use the lowest dose possible to prevent this adverse effect. The drug is indicated for moderate to severe chronic pain in opioid-tolerant patients. The product comes in a variety of extended releases, biphasic release, or rectal suppositories. Rectal suppositories are particularly useful for producing the prolonged effect. It is a very desirable drug among intravenous drug abusers and is not usually prescribed by primary care providers. So the phenylpiperdines and diphenylheptines include the meperidine, fentanyl, and methadone. Meperidine, which is Demerol, is a Schedule II. It's a synthetic opioid analgesic with less potency than morphine. It is used for relief of moderate to severe pain, for preoperative sedation, for postoperative analgesia, for obstetric anesthesia, and when given intravenously, for supportive analgesia. Its use has diminished over the years. It's contraindicated in patients with chronic pain because of the risk of seizure, even those with normal renal function. Its warnings include its use should be used with particular caution, if at all, in elderly patients. It is a drug of choice among drug abusers and must be used with extreme caution. For the pharmacokinetics, the onset of action is more rapid, but the duration of action is shorter than that of morphine. Adverse effects, it causes less sedation and pruritus than morphine. The major metabolite, normeperidine, can cause irritability, dysphoria, and seizures. For drug interactions, when administering with phenylthiazine and many other tranquilizers reduce the dosage by 25 to 50% because these agents potentiate the action of Demerol. For dosage administration, each dose of syrup should be taken with half a glass of water because if undiluted, it can exert a topical anesthetic effect on mucosa membranes. Fentanyl, duragesic, transdermal, or transmucosal, the buccal tablet, nasal spray are also Schedule II drugs. Intravenous fentanyl is a very potent short-acting opioid that is used for relief of moderate to severe pain and for preoperative sedation and post-operative analgesia. A 0.1 milligram dose of fentanyl is equivalent to 10 milligrams of morphine. It's 100 times as potent. Transdermal fentanyl is useful for the outpatient setting for long-term relief of pain, especially for the patient who is unable to take oral medications. It can be useful in tapering opioids and used only in patients with moderate to severe chronic pain and in opioid-tolerant patients aged 2 years and older who require total opioid dose at least equivalent to 25 micrograms per hour patch. Because of the risk of potentially fatal respiratory depression, the patch is not indicated for management of postoperative mild or intermittent pain. Therapy with fentanyl should be initiated with a 25 microgram patch, particularly in the elderly who have decreased fat stores and altered clearance. The agent is very lipid soluble and has enhanced CNS penetration. The patient must have adequate fat stores. The patch strength is roughly equivalent to that of a 12-hour MS Cont dose. It has a depot or holding effect, is deposited in the skin, and will continue to be absorbed for hours after the patch is removed. Fentanyl is also formulated for breakthrough pain. The product is available as a transmucosal lozenge on a stick product that is inserted between the buccal area and the teeth. The patient sucks on the lozenge. Doses include 200, 400, 600, 800, 1200, and 1600 micrograms. It is also available in buccal film and tablet, a sublingual tablet, and nasal spray. The transdermal and transmucosal system is to be used for breakthrough or rescue doses only in hospitalized patients or for those in hospice. Use of the patches in opioid-naive patients, co-use of more patches than prescribed, too frequent patch replacement, and patch exposure to heat may create overdosages and may be life-threatening. For adverse effects or respiratory depressant effects of IV fentanyl is particularly dangerous and mandate that the provider have resuscitative measures and opioid antagonists available, making it unacceptable for the outpatient setting. It does interact with CYP3A4 inhibitors. Dosage administration. The fentanyl transdermal system, the initial dose selection should be individualized. If the patient is opioid naive, start with the lowest dose of 25 micrograms per hour. Generally, however, this is not the first opioid the patient has used, and the fentanyl patch should be used in those with chronic pain whose condition cannot be managed with short-acting narcotics. The usual use of fentanyl transdermal systems is to convert the patient from an oral or parenteral opioids to a transdermal system. To do this, you should calculate the previous 24-hour analgesic requirement, convert the amount to an equivalent dose of oral morphine, and then convert from a 24-hour morphine dose to a transdermal fentanyl dose. The patch should be applied to non-irritated skin on a flat surface of the upper torso. You can clip it, but do not shave the hair. Clean the skin with clear water. Do not use soaps, oils, lotions, alcohol, or any other agents that may irritate the skin or alter its characteristics, and allow the skin to dry completely before the system application is applied. The patch should be applied immediately on removal from the sealed package. It should be pressed firmly with the palm of the hand for 10 to 20 seconds, making sure contact is complete, especially around the edges. Each system works continuously for 72 hours. However, occasionally patients may find they need to replace the system every 48 hours. Remove the old system and apply the new system to a different skin site. The old system should be disposed of carefully. When the patient is wearing the first system, because the peak levels are not reached for 24 hours, the patient may need short-acting analgesics. After 24 hours, assess the efficacy of the system by counting the number of times the patient needs a rescue dose of short-acting analgesia. You need to titrate the dose upward if necessary after use of the initial 3-day system. Because the conversion system from morphine to fentanyl is conservative, about half of the patients will need upward titration. If the patient is using rescue doses of analgesics equivalent to 90 milligrams per 24 hours of morphine, increase the fentanyl system dose by 25 micrograms per hour. After the first titration, titrate upward every 6 days. For delivery rates of excess of 100 micrograms per hour, multiple systems may be used. If the patient requires more than 300 micrograms per hour, change the patient to another method of opioid administration. Remember, it takes about 18 hours for the fentanyl concentration to increase by 50% after the system has been removed. A fentanyl patch can be used to discontinue opioids by wearing the patch, then simply removing and allowing the concentration to gradually decrease. For methadone, this is a Schedule 2. Methadone hydrochloride is a synthetic opioid analgesic that is used primarily in the detoxification, treatment and maintenance of persons with opioid addictions. It may be used orally for management of severe and chronic pain in patients unable to tolerate other narcotics. When used for persons with heroin and other opioid addictions for longer than 3 months, methadone use moves from a treatment phase to a maintenance phase. For warnings of this drug, regulations for its use for narcotic detoxification and maintenance are complicated. These patients need to be referred to pain specialists with experience in the use of methadone. For pharmacokinetics, it's long-acting, 36 to 48 hours, and should be used with caution, if at all, in the elderly. There are some side effects. Those are similar to other opioids. Methadone is less sedating and euphoric than morphine. Respiratory depression and arrest remains one of its serious adverse effects. Methadone does interact with other drugs. Methadone is a major substrate of the CYP3A4 and therefore has numerous drug interactions. You need to look at detailed references for prescribing methadone, and again, these are mostly prescribed at pain clinics. Methadone can also prolong the QT interval, especially when used in conjunction with other drugs in patients with hypokalemia or in those with abnormal liver function tests. Fluoxetine and St. John Swartz both increase metabolism, and their use may result in withdrawal symptoms. For dosage and administration, you need to individualize this treatment for detoxification. Adults, adjust the dose to severity of withdrawal symptoms, 5 milligrams 3 times a day for 21 days, with the dose gradually reduced every few days. For opioid maintenance, it's usually around 40 to 100 milligrams or higher once daily by mouth. For other drugs, the mixed agonist-antagonists, such as Tolwyn, alternative analgesic therapy may be safer and more effective than penzoxin, especially when narcotic therapy is initiated in patients who have not used propoxyphene. Pentazocin is a synthetic opioid that's believed to induce analgesia by stimulating the kappa opioid receptors while blocking the mu receptors. It is used primarily in the relief of moderate to severe pain or as a preoperative pre-anesthetic medication. It is not recommended for long-term use, nor is it recommended for use in the elderly. It's a Category 4 narcotic. It's contraindicated for those with hypersensitivity. It's used with precaution in patients who are emotionally unstable and those who have a history of drug abuse. Both physiologic and psychologic dependence may occur, and the drug should be given under careful supervision. It should be prescribed only in limited amounts. Because the tablets are popular with drug addicts, for intravenous injection, Talwin and X with naloxone was developed. When taken orally, naloxone is not absorbed, allowing the pentazocine to exert its analgesic effects. When the drug is misused by injection, severe effects such as pulmonary emboli, vascular obstruction, occlusion, ulceration, and abscesses, and withdrawal symptoms in opioid-dependent individuals may occur. If patients who are receiving therapeutic doses demonstrate any evidence of hallucinations, confusions, or disorientation, the medication should be discontinued. If patients who have demonstrated dependence on opioids, switching to pentazocine may produce withdrawal symptoms. Finally, it's also known to provoke seizures, especially in those patients with known seizure disorders. It also has similar adverse effects of morphine. In addition, it can cause circulatory depression and shock for the cardiovascular system. CNS, it can cause agitation, clammy feeling, confusion, crying, dizziness, dysphoria, faintness, floating feeling, hostility, lethargy, lightheadedness, nervousness, nystagmus, numbness, paresthesias, syncope, tingling, tinnitus, tremor, unreality, unusual dreams, and vertigo. For dermatological adverse effects, it can cause burning, edema of the face, urticaria, rash, severe sclerosis, soft tissue induration, sting on injection, ulceration. It can depress the white blood cells and can cause transient eosinophilia and may cause speech difficulty. For the partial agonists, these include Ultram or Tramadol. It is not a scheduled drug. It's metabolized by cytochrome P452D6 isoenzymes and has the same warnings for morphine. Seizure risk is present, especially in patients with a history of seizures or in those who are taking medications that increase the risk of seizure. There has been anaphylactoid reactions with this drug, and use caution in combination with the MAOIs, SSRIs, TCAs, and neuroleptics. You need to use with caution and reduce dosages in patients with mild to moderate hepatic impairment. Extended release formulations should not be used in hepatic impairment. You need to use with caution and reduce dosage in patients with mild to moderate renal impairment. Extended release formulations also should not be used with these patients. Adverse effects are similar to that of morphine. The most common is dizziness, vertigo, nausea, constipation, headache, and somnolence. They do interact with inhibitors such as chlorpromazine, Paxil, Prozac, quinidine, quinine, ritonavir, and ropinirole may decrease the effects of tramadol. Use with carbamaxines can cause an increase in tramadol metabolism. It is available in extended release form, 100, 200, or 300 milligrams daily. For tabpentadol, this is a Schedule II drug. It's indicated only for acute pain and diabetic peripheral neuropathy. It may have a lower incidence of GI adverse effects than the morphine or oxycodone. That is a brief overview of the opioid analgesics. You need to become familiar with these, and they're very commonly used in practice. Let's move on to the migraine medications. A wide variety of drugs are used for the treatment of migraines. They are divided into medications that are effective in acute treatment of migraine symptoms and medications used for chronic prophylaxis. The most commonly used migraine medications are those of the serotonin 1, 5-HTI receptor agonists, commonly known as the triptans. Preventive medications approved by the FDA also include beta blockers, calcium channel blockers, TCAs, SSRIs, and anticonvulsants. Headaches represent a very common complaint in primary care. They may have many causes ranging from seriousness from stress to brain tumors. Therefore, the cause must be determined whenever possible for effective therapy to be determined. Tension headaches, the most common type of headaches, usually are described as a vice-like pressure associated with stress and or fatigue. The pain of stress tension headaches usually is generalized, but is maybe worse in the area of the neck and back of head. These patients are generally treated with analgesics for mild to moderate pain. So most of the drugs, we have the abortive agents, the serotonin 5-HT1D receptor agonists. These are the triptans, the serotonin 5-HT1B1D receptor agonists, and the ergotamine derivatives. We have the prophylactic agents as well. Drug classes commonly used for prophylaxis include the analgesics, the beta blockers, the calcium channel blockers, antidepressants, and anticonvulsants. All 5-HT1 receptor agonists, the triptans, have a similar clinical structure and comparable mechanism of action. The 5-HT1B and 5-HT1D receptors are located on the extracerebral intracranial blood vessels that become dilated during a migraine attack and on nerve terminals in the trigeminal system. Therapeutic activity caused by activation of these receptors, which results in cranial vessel constriction, inhibition of neuropeptide release, and reduced transmission in trigeminal pain pathways. Each product varies with regard to onset of action, duration of action, and incidence of recurrent headaches. The ergotamine derivatives demonstrate partial agonist and or antagonist activity against dopaminergic, tripinergic, and alpha-adrenergic receptors, depending on the site. Ergotamine derivatives have three primary actions. One, they depress central vasomotor centers. They constrict peripheral and cranial blood vessels and reduce extracranial blood flow and decrease hyperperfusion of the basilar artery area. In unrelated actions, these drugs also increase the force and frequency of uterine contractions. Ergotamine titrate is an alpha-adrenergic blocking agent with direct stimulating effects on the smooth muscle of the peripheral and cranial vessels. Ergot drugs also produce an increase in central vasomotor center stimulation. Although the dihydroergotamine, DHE, is an ergot, it is also a 5-HT1B/1D receptor agonist that is not as selective as the triptans. The DHE binds to norepinephrine, noradrenaline, alpha-1, alpha-2A, and alpha-2B, and dopamine, D2L, and D3 receptors. It is a stronger vasoconstrictor and a weaker arterial vasoconstrictor than the ergotamines. The abortive agents, mechanism of action. Ergotamine tartrate, alpha-adrenergic blocking agent, Direct stimulating effect on the smooth muscle and peripheral and cranial vessels. It's a stronger vasoconstrictor and weaker arterial vasoconstrictor than ergotamine. Combination drugs are the isomethylpermethacate is a simple mimetic agent that acts as a vasoconstrictor of dilated cranial and cerebral arterioles. Midrin is a combination capsule that contains 65 milligrams of isomethylpermethacate, 325 milligrams of acetaminophen, which exerts an analgesic effect, and 100 milligrams of dichlorphenazone, a mild sedative that acts centrally to allay anxiety. Caffeine, which is added to many of the migraine combinations, helps to promote constrictive properties and enhances absorption. Aspirin, acetaminophen, ibuprofen, and caffeine, all which are commonly found in combination analgesic products used for the treatment of patients with mild to moderate migraines, have been shown through evidence-based studies to be effective in the prophylaxis and treatment of migraines. For the prophylactic agents, the beta blockers are postulated to exert anti-migraine effects through stabilization of vascular tone. Mechanisms by which this stabilization may occur include inhibition of norepinephrine release by blocking prejunctional beta receptors, by reduction in enzyme activity, that is the rate-limiting step in norepinephrine synthesis, and delayed reduction in locus coeruleus neuron firing. Blocking of central beta receptors interferes with the vigilance, enhancing adrenergic pathways that are important in headache prevention. Interaction with serotonin receptors by some beta adrenergic blockers may stabilize vascular tone. Calcium channel blockers regulate cellular functions, including vascular smooth muscle contraction, neurotransmission, and hormone secretion enzyme activity. These products also block intracerebral vasoconstriction caused by vasoactive neurotransmitters such as serotonin and norepinephrine. In addition, calcium channel blockers may impede neurovascular inflammation and prevent hypoxia of cerebral neurons. The tricyclic antidepressants act to reduce migraine activity by increasing the availability of synaptic norepinephrine or serotonin downregulation of 5-HT receptors and beta receptor density. Thus, they enhance the opiate mechanism and provide inhibition of 5-HT and norepinephrine reuptake, while binding to the receptors on platelets and neurons that are blocking the 5-HT uptake. The net result is an increased threshold of precipitation of a migraine attack in selected individuals. The SSRIs are potent, specific 5-HT receptor reuptake inhibitors that reduce migraine frequency and intensity. They act to prevent vasoconstrictive effects of decreased serotonin levels during headaches. Such constriction sets up a cascade of neuron inflammatory changes that produces headache pain. Maintaining the serum level of 5-HT with SSRI prevents initiation of this pathway, thereby preventing the migraine. Anticonvulsants are believed to exert anti-migraine activity through the influence of cerebral arteries and circadian rhythms. They also may help to regulate secretion of hormones from the anterior pituitary gland that help to relax vascular structures. So what are the treatment principles? Cardinal points of treatment: you need to establish a diagnosis, establish a realistic patient expectations through education and counseling, and treat acute attacks rapidly and consistently. First line usually are the triptans, second line usually DHEs, third line include combination analgesics of non-steroidal anti-inflammatories, aspirin, and caffeine. Emergency rescue drugs include prochlorperazine, IM, IV, or rectally by suppository, opiates, corticosteroids, and you need to encourage the patient to identify and avoid any triggers. The goals of migraine treatment are to correctly diagnose a headache, to decrease pain and associated symptoms, to prevent recurrence, to improve quality of life and allow the patient to function, maintain their function. Treatment of migraine headaches must be individualized for the patient. For acute treatment in children, nasal spray is effective, the triptan nasal spray, but no evidence is there to support the use of oral triptans in children. Again, preventative treatment in adults. For the triptans, children, there is insignificant evidence to recommend any treatment. Prophylactic medications typically are used when patients experience more than 2 to 3 attacks each month, or when headaches do not respond adequately to abortive medication. Quality of life may be so poor that products have to be used. These products may not eliminate migraine headaches, but do decrease their frequency, intensity, and duration. Best evidence for use is available for propranolol, timolol, amitriptyline, valproate, and topramate. You need to select a medication that has low adverse effects and is compatible with the patient's coexisting conditions. Use once daily dosing if possible to improve compliance, and start slow and gradually increase the dose until headache is relieved or the patient has side effects. Give the medication on an adequate trial of at least 2 to 6 months, and consider tapering medication if headaches are well controlled after 6 months. Beta blockers reduce headache frequency and severity in 60 to 80% of the cases. Propranolol is most commonly used. Atenolol, metoprolol, and nadolol also have been shown to be effective. Gradually increase dosage to minimize adverse reactions. 3 to 4 weeks of therapy are required before effectiveness can be evaluated. These agents may aggravate neurological symptoms associated with hemiplegic or basilar migraines. Second-line agents include calcium channel blockers. These agents decrease headache frequency, intensity, and duration in 40 to 60% of migraine patients. Verapamil is used most commonly. Clinical improvement may not be noted for 4 to 6 weeks after initiation of therapy. As with many other products, tolerance to calcium channel blockers commonly develops. Tricyclic antidepressants are also used in prophylactic treatment of patients with migraines. Amitriptyline is considered first line. The others are considered second line. TCAs provide sedation and stabilization of the sleep cycle. Disruption of the sleep cycle is a common problem with patients with migraines. Amitriptyline, doxepin, nortriptyline, and imipramine are the more sedating TCAs. Less sedating include the protriptyline and desparamine. Tricyclics are rapid-acting, providing benefit to 60% of individuals within 10 to 14 days. Dosages required for migraine treatment are lower than those needed for the treatment of mood disorders. SSRIs are considered second-line treatment. They are less effective than the TCAs. The fluvoxamine and paroxetine have been studied most extensively. The anticonvulsants have also been used for severe migraines. Again, the goal is decrease pain and associated symptoms, prevent recurrence, improve quality of life, and allow the patient to maintain function. For non-pharmacological treatment, although many medications exist, management of migraine headache has a lot to do with the willingness to explore sources of stress and anxiety, to teach patients about migraine headaches and work with them using multiple strategies to reduce stress and triggers in their life. Prevention or reduction of episodes of migraine requires healthy, regular daily habits pertaining to sleep, meals, and exercise. Patients should avoid peaks of stress and troughs of relaxation because acute stress and the abrupt removal of stress are common triggers. Regularly of habits rather than just searching for triggers is essential for enhancing the effectiveness of non-pharmacological approaches. The second step in the management of migraine headaches involves the identification and avoidance of headache triggers. The patient should try to determine the factors responsible for initiating his or her headache. Have the patient keep a diary that correlates with the patient's activity, food, and stressful events with occurrence of migraines. Common migraine triggers include loud noises, strong smells, perfumes, flashing lights, illness, a customized exercise, activity, change in sleep pattern, change in time zones, weather and altitude changes, tobacco smoke, and menstruation. Food triggers include changes in eating pattern, caffeine withdrawal, aged cheese, chocolate, MSG, nitrate, nitrite, preserved foods, glutamates, excessive vitamin A, and alcohol. Psychological stressors or stress cessation may serve as a trigger. Drug triggers include oral contraceptives, nitroglycerin, histamine, risperidine, corticosteroid withdrawal, and hydralazine. Treating headaches with narcotics and barbiturates increase the risk of developing a chronic migraine. Frequently, the patient will not be able to identify their specific triggers. Treatment of the acute attack begins with resting in a quiet, dark place. This reduces external stimuli and allows the patient to relax. Sleep has been found to reduce the duration of headache. Other effective techniques include local pressure, acupuncture, Botox injections, local application of cold, and sleep. These approaches frequently are not feasible when people are at work or have responsibilities that they must meet. Relaxation training, thermal biofeedback, and cognitive behavioral therapy may help to prevent migraines. Alternative therapies that have been described in the evidence-based literature include feverfew, riboflavin, and magnesium. Pharmacological treatment factors that the clinician should consider when determining the appropriate drug therapy include frequency, duration, and severity of headaches, symptoms other than pain such as nausea, and therapies that have been tried previously. Complicated and transformed migraine should be managed by a specialist. All patients should have abortive agents on hand. They're used in the absence of prophylactic management in patients who have fewer than 4 attacks per month. Abortive agents should not be administered on more than 2 days per week. Abortive treatment, patients in whom migraines have been diagnosed should have medication on hand in anticipation of an acute migraine attack. Abortive agents are used in the absence of prophylactic management in patients who have less than, again, 4 attacks each month. It's important that any abortive agent be administered no more than 2 days per week to avoid the possibility of rebound headaches. Usually patients who will have headaches of variable intensity, so they should be given different treatment options to try. No drug works perfectly every time. Patients should be encouraged to try products for at least 2 or 3 episodes of migraines before they decide they are ineffective. The major initial treatment choices involve selections between ergots and triptans. Triptans have become the first-line treatment for abortive treatment of migraines. In general, triptans cause fewer adverse reactions, but some patients may be unable to tolerate them. Triptans are also expensive. Ergotamine formulations are effective and cost less than the triptans. If the patient is able to take medications at the earliest onset of headaches, ergots usually are effective. If the patient wakes up with a headache or has difficulty catching the headache in time, a triptan will be more effective. All triptans and ergotamine drugs have the same cardiovascular cautions. Mild to moderate migraines, Analgesics such as aspirin, nonsteroidals, or combination products are commonly used. Combination over-the-counter migraine medications that contain aspirin, acetaminophen, and caffeine are approved for migraine treatments. Commonly used nonsteroidals such as naproxen and ibuprofen are effective. Indomethacin is more often effective than other nonsteroidals. For nausea and vomiting, administer triptan, migraine medication in nasal spray or injection formulation for patients who have severe nausea or vomiting and are unable to take oral products. Nasal spray is easy to use and is effective for mild to moderate migraines. Commonly used antiemetics include compazine and Tygan. Reglan has an added effect of speeding up absorption of other drugs and is used with aspirin for mild to moderate migraines. Although it appears to be most effective antiemetic, Reglan has potential serious adverse reactions. For the moderate to severe migraine, evidence-based studies suggest the triptans are first-line drugs and are generally very effective. Ergotamine, Teratrate may be used if triptans are not effective. DHE, which is very effective for severe migraines, is available in nasal spray or intramuscular or subcutaneous injections for the treatment of patients with minor to severe pain. It produces a quick response and a low recurrence rate. If triptan drugs have not been adequate, DHE is a good second-line drug to try. For migraine recurrence, they may recur within 24 hours after initial medication in 30 to 40% of the patients. Research meta-analysts suggest that clinicians should consider giving a long-acting triptan such as frovitriptan. Severe migraines, consider injections of a triptan or DHE. These are generally very effective. Corticosteroids or opioids may be required as rescue medications. Corticosteroids should be administered intravenously, intramuscularly, or orally at 2 to 4 milligrams twice a day for 2 days and tapered over 3 or more days at one event per month. Opioids can be used for patients who have infrequent but severe migraines. If rescue medications are required, re-examine the patient for whether he or she is using other medications correctly in terms of dosage, timing, etc. How to monitor these medications. A patient should develop a habit of keeping a headache diary to document the frequency and severity of their headaches and help identify triggers. Patient should bring a diary for review by the provider at regular intervals. When using triptans or ergots, monitor cardiovascular status with periodic ECGs and cardiac enzyme labs. For those patients who are taking cryptoheptadine, liver function studies should be performed at regular intervals. Patient weight should be checked and monitored for normal weight gain. Questions regarding anticholinergic side effects such as dry eyes, dry mouth, constipation, urinary retention, and excessive drowsiness should be included in a general follow-up assessment. The effectiveness of cyproheptadine is apparent within 3 weeks of treatment initiation. For patient variables, geriatric patients use all products with caution because elderly are more susceptible to the adverse effects than the younger patients. Begin with very low dose and increase slowly. Although many individuals with a lifelong history of migraine report a decrease in headache during their 50s, migraines are very rare in older patients, and an intracranial lesion should be suspected. New headaches in this age group require further comprehensive evaluation. For pediatric patients, children migraines frequently last less than 2 hours. The safety and efficacy of most migraine medications has not been established in children. Triptan, nasal spray, and ibuprofen are effective and well tolerated. Acetaminophen is probably effective and is well tolerated. Although evidence does not support the recommendation of any prophylactic medication in children, cryptoheptadine often is used, as in those younger than age 2 is contraindicated. Sumatriptan is used by clinicians in children older than 5, but this drug has not been FDA approved. For those patients who are pregnant and lactating, cratoheptane is considered Category B. The triptans are Category C, and they may be secreted in the breast milk. And ergotamines are Category X. They should not be used in women who are likely to become pregnant. For gender, the incidence, 3 times as many women have migraines than men. The frequency and severity of migraines often decrease or change character in postmenopausal women. For patient education, extensive education regarding diagnosis, disease course, lifestyle modifications, and treatment medications and their uses and side effects is necessary so the patients can make decisions and manage their headaches when they occur. Education should include the use of product for no more than twice a week to avoid rebound headaches, instruct patients on how to use the medication, particularly nasal sprays and injections at the first sign of pain. The patient should avoid alcohol with these medications and report any adverse symptoms at their first occurrence. Prophylactic agents, patients should take the product daily regardless of whether they have headache symptoms. It often takes 3 to 4 weeks or more to determine the efficacy of specific products. For the abortive agents, a serotonin 5-HT1D receptor agonists such as Imitrex are contraindicated for those with hypersensitivity or those with significant cardiac disease such as coronary artery disease, stroke, TIAs, uncontrolled hypertension, peripheral vascular disease, ischemic bowel disease. They're contraindicated for those patients with basilar artery, hemiplegic, or complicated migraines, in those with who are on MOAs, ergots, or SSRIs, and those individuals younger than 18 years of age, for those that are pregnant and those with severe hepatic impairment. Warnings include a risk of myocardial ischemia or infarction and other adverse cardiac events. These agents have the potential to cause coronary vasospasms. Do not give to patients with cardiac risk factors unless a cardiovascular evaluation shows no underlying disease. Give the first dose in the office with adequate medical equipment. Consider obtaining an EKG during administration. Ventricular fibrillation, tachycardia, and myocardial infarction has occurred with Imitrex. Cerebrovascular events and fatalities include cerebral hemorrhage, subarachnoid hemorrhage, stroke, and other cerebral events may be seen with Imitrex. Marked increased blood pressure, including hypertensive crisis, has been reported. The nasal spray may cause local irritation. Hypersensitivity reactions are rare, but severe anaphylactic reactions have occurred in patients. And hypersensitivity and renal function impairment, you need to use with caution for those patients on Imitrex and rizatriptan. Hepatic function impairment, you need to administer with cautions. Doses must be decreased, and carcinogenesis and impaired fertility has been observed in animal studies. For precautions, chest, jaw, or neck tightness has occurred after administration of Imitrex. Monitor for angina. Seizures have occurred rarely, and ophthalmology effects has been seen. This medication binds to melanin. It can accumulate over time, causing corneal effects in animals, and photosensitivity may occur. For the pharmacokinetics, onset of action varies among these agents. The Imitrex have an onset of action of less than 2 hours. Others take longer. Duration of action is also a consideration. Provatripin, triptan lasts the longest. There are some adverse effects and drug interactions. Samantidine may increase drug levels, and other of those from the CYP3A4 inhibitors. Cataconazole increases levels of amitriptan. Oral contraceptives increase levels of frovatriptan. Propranolol increases the levels as well. And triptans increase levels of SSRIs. You should look these up when prescribing these medications and make sure that these patients are not on any medications that may have adverse effects. For overdosage, symptoms to be expected include hypertension and other more serious cardiovascular symptoms such as pressure in the chest, palpitations, pain, and shortness of breath. For administration, patients should take the initial dose at the first sign of the migraine. If the first dose is not effective, patients may repeat the dose once gradually. After 2 hours, patients should repeat the same dosage as their initial dosage. With the next migraine, patients may start with a higher dose if the first dose was ineffective. Do not give any more triptan within the 24-hour period. Patients should administer a triptan no more than 2 days per week. A 24-hour space should be taken between the use of these medications and the use of an ergot. The most commonly used formulation is a tablet. A nasal spray will work if the patient has nausea and vomiting that interfere with absorption of the tablet. Orally disintegrating tablets dissolve on the tongue, requiring no water. This makes it very convenient as a dosing system. Patients with severe migraines prefer the injection formulation because it has a faster onset of action. The thigh is the preferred site of injection. The initial dose, whether oral, nasal, or subcutaneous injection, should be administered in the office so the provider can monitor blood pressure and pulse. In addition, the provider should be present to answer questions about any side effects that may occur. Other drugs in these class are similar, except all drugs in this category, the only difference lies in their pharmacokinetics. Relpax is a potent 3YP3A4 inhibitor. Concentrations may increase up to 4-fold if given with ketoconazole, itraconazole, clarithromycin, erythromycin. Studies suggest faster headache relief and less headache recurrence with this drug compared to the other triptans. For the ergotamine derivatives, they're contraindicated again in coronary heart disease or coronary artery spasm, uncontrolled hypertension, impaired hepatic renal function, hemiplegic or basilar migraines, and at the same use with peripheral and central vasoconstrictors. They're contraindicated in pregnancy in women who want to become pregnant. Uterine stimulant actions may cause fetal harm, and the patient should not use ergots within 24 hours of using triptans. Finally, we'll move on to substance abuse. Again, this is very common in practice, and you as a provider needs to be aware of this. Some of the drugs used for substance abuse include alcohol treatment and opioid treatments. Alcohol includes benzodiazepines, opioid antagonists, and aminobutyric acid analogs, aldehyde and dehydrogenase inhibitors. For the opioid treatment medications, these include antagonists, agonists, partial agonists, and partial agonists with antagonists. Indications for alcohol use disorders: benzodiazepines are used for withdrawal. Naltrexone is an opioid antagonist. It decreases the intake craving. Acamprostate decreases intake, and dalsulfiram is an adverse agent. For opioid use disorders, opioid antagonists are used for overdoses such as naloxone, opioid blockage such as naltrexone. Opioid agonists are used for withdrawal, maintenance, such as methadone, and partial opioid agonists for withdrawal maintenance, such as buprenorphine. Unlabeled uses, alcohol withdrawal and cravings include topramate and carbamazepine, and alcohol dependence. There has been some studies on Chantix, which is currently approved only for smoking cessation. For alcohol withdrawal treatment, benzodiazepines demonstrate cross-tolerance with alcohol via GABA receptors. Long-acting benzodiazepines such as diazepam or chlorodiazepoxide generally are preferred to minimize the occurrence of breakthrough agitation and seizures. Short-acting drugs such as lorazepam and oxypam are used in patients with severe liver disease. The naltrexone is an opioid agonist with highest affinity for the mu opioid receptor. Occupation of opioid receptors by naltrexone may block the effects of endogenous opioid peptides. The neurobiologic mechanism responsible for the reduction of alcohol consumption observed in alcohol-dependent patients treated with naltrexone are not entirely understood. However, involvement of the endogenous opioid system probably has its effect on alcohol consumption. Naltrexone has some effect on cravings for alcohol. It does not cause physical adverse effects that are produced by the disulfiram. Naltrexone blocks opioid receptors that are involved in rewarding effects of drinking alcohol and the cravings after abstinence is established. The acrophosphate is structurally related to GABA agonists and potentiates the inhibitory effects of the GABAergic system. Patients with alcohol dependence normally display an imbalance of GABA and glutamate neurotransmission, which may be restored by this drug. This agent decreases glutamatic transmission and modulates hyperexcitability during alcohol withdrawal from. It also reduces voluntary intake of alcohol, but does not cause a disulfiram-like reaction. This drug is possibly helpful with regenerating neurotransmitters and restoring the balance between GABA and the glutamate when alcohol intake is stopped or has been significantly decreased. The disulfiram, a potent alcohol dehydrogenase inhibitor, blocks the oxidation of alcohol at the acetaldehyde stage by inhibiting the enzyme aldehyde dehydrogenase. The alcohol ingestion with alcohol ingestion, disulfiram causes the patient to feel extremely unpleasant sensations ranging from flushing, dyspnea, and tachycardia to confusion, vomiting, and syncope. Unpleasant symptoms can last from 30 minutes to 2 hours, and the intensity of the reaction depends on the amount of alcohol ingested, the dose of the disulfiram taken, and the time that has elapsed between the two. The theory behind this drug is in the treatment of alcoholism is based on aversion. Acute reactions may be fatal. Topiramate is a seizure medication that can help curb the craving for alcohol. The drug acts by reducing excess dopamine release through alcohol consumption. Researchers have found that patients given this drug were 6 times more likely than those taking a placebo to abstain from alcohol for a month. Buprenorphine exerts an analgesic effect via high-affinity binding to opioid receptors in the CNS. It displays partial mu agonist and weak kappa antagonist activity. So what are the cardinal points of treatment? The principles behind using medication for alcohol treatment involves helping patients who are dependent on alcohol reduce their problematic drinking, deterring relapse back to heavy drinking, achieving and maintaining abstinence from alcohol, or a combination of these effects. Pharmacological treatment options include oral medication, naltrexone, a long-acting injectable form, vitriol, acamprosate, and disulfiram. Disulfiram functions on the aversion model and is a significant physical deterrent to alcohol because it causes the unpleasant physical symptoms when alcohol is ingested or inhaled. These drugs may be taken while people are still drinking, except for the disulfiram. During the initial acute phase of alcohol withdrawal, up to 5 days, benzodiazepines help to physiologically stabilize the patient. Medication use is successful with programs that integrate social support to motivate and educate patients on the adverse effects of alcohol and to help them redirect their lives. For treatment of drug-related problems, naltrexone injectable can be used to reverse the signs of respiratory depression in patients with opioid overdosage. For alcohol withdrawal, benzodiazepines play a large role in preventing seizures and other complications. For milder symptoms, clonidine, atenolol, and carbamazepine has been used successfully. There is a tool called the Clinical Institute Withdrawal Assessment for Alcohol Scale Revised. A CWA tool has been designed to evaluate the need for medical treatment for withdrawal and includes an interactive training package that is suitable for practitioners who treat patients with alcohol misuse. For opioid abuse treatment, naloxone is an opioid antagonist with a short duration of action, 20 to 60 minutes. It's given sub-Q, IM, or by continuous IV infusion. This is generally done in the emergency department setting to counter respiratory depression during an opiate intoxication. Naltrexone is considerably more active than naloxone and has a 24-hour duration of action. Opioid antagonist activity is related to dose. A single 50 to 100 milligram oral dose of naltrexone effectively antagonizes the pharmacological effects of 25 milligrams of IV heroin for up to 24 hours. A single IM injection may antagonize heroin or other opiates up to 2 to 4 weeks. Nalmefene, which is structurally related to naltrexone, is indicated for the reversal of opioid effects and for opioid overdose. It has a longer duration of action than naloxone at fully reversing dosages. Methadone is dispensed by both pharmacies and licensed narcotic treatment programs approved by the DEA and designated state authorities. Strict requirements for the use are stipulated in the federal methadone regulations. Methadone used as an analgesic may be dispersed in any licensed pharmacy. Buprenorphine, or a combination of buprenorphine and naloxone, is a sublingual treatment that is started when the patient experiences signs of withdrawal. So how do we monitor these patients for naltrexone? We need to monitor heart rate, blood pressure, and respiratory rate, kidney and liver function, response to therapy, and abstinence from alcohol. And the risk of suicide is often increased in those with substance abuse problems. So you need to monitor for this as well. For the acamprosate, it should be used with renal impairment with a creatinine clearance less than 30. It may be given if a creatinine clearance is 30 to 50. I'm sorry, I'm going to say this again. It should not be used with renal impairment with a creatinine clearance of less than 30, but may be given to those with a creatinine clearance between 30 to 50, as long as the patient is monitored regularly. Again, the risk of suicide is increased in these patients. For disulfiram, you need to monitor for liver toxicity, check LFTs at baseline weekly for 4 weeks, biweekly for 4 weeks, then monthly. Monitor for jaundice or for evidence of liver toxicity. Monitor for symptoms of optic neuritis, such as eye pain or visual disturbances. Monitor for symptoms of peripheral neuritis, such as tingling and numbness in the hands and feet. And monitor for headaches, drowsiness, or psychotic reactions. Assess compliance with drug therapy, abstinence from alcohol use, and progress of therapy. For patient variables for geriatric patients, naltrexone you need to use with caution with renal and hepatic failure, most commonly seen in geriatric patients. For the acamprosate, has not been evaluated. Use caution when monitoring renal function in the elderly, and the disulfiram of limited benefit in geriatric patients because of the cardiac risks. For pediatrics, the use of these medications have not been evaluated, and for those pregnant and lactating, category C for naltrexone, acamprosate, and disulfiram, lactation safety is unknown. For patient education, for naltrexone, tell the patient to wear a med alert bracelet or carry ID and notify healthcare providers that they're taking this medication. Tell the patients that if they take heroin or other narcotics with these drugs, they may die or sustain other serious injuries, including coma. Tell the patient if the patient previously used opioids, they may be more sensitive to them after using Vivitrol. Healthcare providers should monitor for signs of liver toxicity, such as abdominal pain, white bowel movements, dark urine, or yellowing of the eyes. With Vivitrol, if patients have signs and symptoms of pneumonia or respiratory distress, they may have allergic pneumonia, which requires special medical treatment. Again, with Vivitrol, if the injection site exhibits a reaction, that does not resolve. Patient should be seen once the patient receives the injection. It cannot be removed. If they become pregnant or are lactating, patients must notify their healthcare provider. For the acamprosate, the patient may take this agent with other alcohol treatment medications, but not with moderate kidney failure. And if the patient's feeling depressed, the patient should notify the healthcare provider. With disulfiram, you need to instruct the patient to avoid taking this medication if they are unwilling to make the commitment to not drink alcohol. Tell the patient to wear a med alert bracelet and notify the healthcare provider if they're taking this medication. Tell them that a reaction can occur up to 14 days after the medication is taken, and seek medical attention or notify a healthcare provider immediately if the patient experiences any chest pain, respiratory difficulty, or jaundice. Healthcare providers should monitor for signs of liver toxicity, such as abdominal pain, white bowel movements, dark urine, or yellowing of the eyes. And the patient should be told if feeling depressed, they should notify their healthcare provider. And finally, for alcohol treatment agents, naltrexone is used for extended release injectable suspension, the Vivitrol or Rivera. These are contraindicated for active narcotic use. Patients who receive opioid analgesics or who have current physiological opioid dependence. Contraindicated for moderate to severe renal failure, and there is a black box warning for hepatocellular injury may occur when given in excessive doses. Naltrexone is contraindicated in hepatitis or liver failure. The therapeutic margin of treatment is narrow. The safe dose of naltrexone and the occurrence of hepatic injury are less than 5-fold separation. Vivitrol itself does not appear to act as a hepatotoxin at recommended dosages. For the Campro or acamprosate, it's contraindicated with any known hypersensitivity in patients with severe renal involvement. And the disulfiram is contraindicated with commitment use of alcohol, severe myocardial disease or coronary occlusion, hypersensitivity to disulfiram or other therum derivatives such as pesticides and rubber, vulcanization. Patients who have recently received metronidazole or flagyl, aldehyde alcohol or alcohol-containing preparations such as cough syrups, candy-containing liquors, or alcohol-based flavoring extracts. This drug is contraindicated. Again, there is a black box warning for disulfiram. It should never be administered to anyone under the influence of alcohol without the patient's full knowledge and consent. A disulfiram alcohol reaction produces extremely unpleasant effects that can be severe. In vulnerable patients, this may provoke respiratory depression, cardiovascular collapse, arrhythmias, myocardial infarction, acute CHF, unconsciousness, convulsions, and death. And the opioid treatment medications, we have the methadone and the naltrexone. These should be used primarily by drug treatment centers, pain management centers, or by licensed prescribers.